my name's Sepi Hanjani. I'm Stroke Council Chair and a vascular neurosurgeon at University Hospitals, Cleveland Medical Center, and Case Western School of Medicine. It's my distinct pleasure to be speaking with the principal investigator of the Resilient Extend trial, Dr. Raul Nogueira, who is the professor of neurology and neurosurgery and director of the UPMC Stroke Institute, and is presenting this trial today here at ISC 2024. So welcome, Dr. Nogueira, and we'd love to hear a little bit from you about the premise for this trial. You were the principal investigator of the Resilient trial previously. Tell us how you expanded that effort into Resilient Extend.
Thank you, Sepi. It's a pleasure to be talking about the results of our now second trial, acknowledging all the help and support of our colleagues in Brazil and my co-PI, Sheila Martins. So we put the Resilient Network together a few years ago with the goal of eventually bringing thrombectomy to the public healthcare system of Brazil. So I think we tend to have a very myopic view of stroke treatment by living in first world countries where things tend to happen a lot faster. As a background, it took Brazil 17 years to approve the reimbursement for intravenous thrombolysis in the public healthcare system. And you may say that's bad, right? But Brazil was the first BRIC country. If you look at Russia, India, China, South Africa, you were the first country in the BRIC bloc to actually approve and pay for intravenous thrombolysis in the public healthcare system. So you wanted to catalyze, to accelerate the process for thrombectomy, giving its huge benefit. However, you do acknowledge there are very unique aspects to the care of these patients in the public healthcare system, as well as to the population itself. And we conduct the first randomized clinical trial focusing the 0 to 8 hours. It was a trial that was very similar to, let's say, Revascat or Escape. That trial was highly positive, very much like the other trials. We published it in 2020 and start to work with government towards reimbursement now that you had the ultimate proof that it worked even in our reality. There were a few things that caught our attention in Resilient though. Very much in alignment with the greater vulnerability of the population that you were treating. We perceived that even though the treatment effect size was the same, was just as big as, let's say, Revascat, okay, the overall rates of good and excellent outcomes, they tend to be lower, but the thing that mostly caught our attention was mortality. We know that more vulnerable populations, right, lower socioeconomic status, they have greater case fatality after a stroke. And we actually saw this in Resilient. The 90-day mortality in the first Resilient was 1.5 to 2.5 times higher than the overall mortality in the other trials at 90 days. The other finding is, in general, if you look at the Hermes meta-analysis, which encompasses all these trials performing in first world countries, the treatment effect size, it actually increases in elderly people. Even though the elderly, they do worse with the treatment than the younger, without treatment, they do a lot worse. So the treatment effect size is actually bigger in the elderly, at least numerically. But in Brazil, you saw the exact opposite. Calling elderly patients there, 70 or older, we actually could barely show even a numerical benefit, and it was not statistically significant with odds ratio very close to 1. So this helps us preparing the second stage. So the goal of the Resilient Extend trial is now that you had proof that you could do this treatment in the 0 to 8 hours, you want them to expand the window, but you wanted to do so without the means of using advanced imaging with CT perfusion or MRI. So we came up with an approach that was completely based on non-contrast CT and CT angiography, okay? And capitalizing on our overall knowledge about the dissociation between clinical findings, high NIH stroke scale with aspects, but also adjusting the amount of injury that people could have on imaging for the age of the patients. So you came up with the age-adjusted clinical aspect mismatch concept, and you test that in the Resilient Extend trial.
I think you've highlighted here in describing the premise for this, the different populations and the vulnerability of certain populations to potentially different outcomes. Tell us a little bit about the patient population that you ended up enrolling and the results that you saw.
Right. So our initial sample size was 376 patients. We initially planned 2 interim analyses. However, the government contacted us to say that thrombectomy would be approved and paid for in the public healthcare system. So we decided not to do an interim analysis and keep enrolling until the time of that approval. At the end, we enrolled 245 patients, 126 patients thrombectomy, 119 patients in the control group. Essentially, these patients tend to be younger than what you see in the higher income countries. So as you know, stroke tends to happen at a younger age in this more vulnerable population. The mean age was about 62, 63, which is slightly younger. The median age stroke scale was 16, so within the normal range you always see. The mean time from last seen well to treatment was just about 12 hours, pretty much between dawn and diffuse 3, and very similar to Mr. Clean. And in terms of findings, our primary endpoint was the ordinal shift analysis. But what you found in the trial is that the chances of having excellent and good outcome were significantly higher with thrombectomy. But once you got to the chances of having, let's say, a 0 to 4 versus a 5, 6, or a 0 to 5 versus a 6, those chances were lower with thrombectomy. And that kind of creates a problem when you try to come up with a common odds ratio for your results, because essentially you're violating the proportional odds assumption. So you couldn't really calculate a common odds ratio. If you're going to calculate one, it would be very close to 1 and not significant. But we then have to jump to our secondary clinical endpoint of significance, which is the rate of functional independence at 90 days. And that was significantly higher with thrombectomy, with an odds ratio of approximately 2.6, favoring thrombectomy, and about 26% of the patients in the thrombectomy arm achieve MRS 0 to 2 at 90 days versus less than 15% in the control group, so an absolute difference of over 10%.
Yeah. So still a large effect size of at least the good and excellent outcomes. And I think it'd be helpful for our audience to kind of contrast that with other studies, again, showing that these populations are somewhat different. How do those results compare to what we're seeing with prior trials?
So our results contrast with the results of the previous thrombectomy trials, again, all done in higher income countries, due to 2 main reasons. One is, again, it's a more vulnerable population, public health care of a developing country. And number 2 is we use a very simple selection paradigm, which is our main goal. Our main goal was to show you do not need advanced image like we require in DOM and diffuse 3 to include more patients and facilitate the workflow and the treatment globally. Well, when you do that, we still keep a very robust treatment effect size, around 10% absolute benefit, a number need to treat of 9, which is still spectacular, but not as low as you had in DOM and diffuse 3, because again, there you are over-selecting, and you are also treating a population that potentially does better with treatment. When you look at the absolute numbers, the chances of having functional independence is 25%, right? It's not that 45, 50% that you have seen in other studies. It's kind of between what you saw with those more well-selected or over-selected studies and what you have now with these large core trials. So I think what you're learning now is that as you approach different populations and different selection paradigms, we're going to have different results, but I think what really matters is the presence of the treatment effect. And I think that has been a constant in all these thrombectomy trials. It's such a powerful treatment that regardless of the population, geographic location, clinical setting, that treatment effect persists. One of our main concerns is very much like we saw in the first Resilient. In Resilient Extend, the elderly population didn't show a benefit. So we had odds ratio very flat, very close to 1. And when you exclude the elderly, the patients that are 68 or older, we have then results that are a lot more robust, that more close mimic what you see in first world countries. So, and again, we are calling elderly here people that are on average 70 and older, not even 80 and older, which also speaks to the point of this mismatch between chronological and biological age as you depart from a high income situation to a low middle income situation.
How do you see now with these results in hand and knowing that there are commonalities in the effect size, at least relative effect sizes seen, and the difference in populations being important, how to use this information in other populations now? How do we interpret this, or how do practitioners use this data in their day-to-day management?
I think there are two key conclusions here. One is, yes, we can use non-contrast CT and CTA only to select patients in the extended time window, and you have a benefit. So I think these guidelines, right, requiring advanced image have to be now revised after Resilient Extended and Mr. Clean Late results showing that you can have simpler, more inclusive paradigms that will hopefully benefit more people. Even though the treatment effect size is lower, you're going to treat more people, so you're going to benefit more people. I think that's perhaps the most important conclusion. The second conclusion is a little bit of a word of caution, mostly after these 6 randomized clinical trials that we are all very happy about, right? Showing that there is a maintained benefit even in these large infarcts, right? So the pendulum of clinical evidence, right, went from down diffuse 3 over selection to down large core trials positive. You can treat everyone. And I actually think Resilient Extend helps that pendulum, right, bringing it a little bit more, well, maybe thrombectomy for everyone shouldn't be applied everywhere, right? So there are, again, nuances about what is the best use of resources. There are financial constraints, right, to these treatments as you depart from the ideal reality of the first world countries that you have to consider. And when you are dealing with very small or perhaps no treatment effect, I think specifically in this elderly population, even with small to moderate size infarcts, I think this idea that you can treat any core size anywhere in the world has to be rethinked.
All right, thank you, Dr. Nogueira, for your interpretation of the study results, and congratulations on completion of the trial. I think we also want to acknowledge that your work and your colleagues have really opened the door for that treatment becoming available in Brazil, and making that treatment reimbursable certainly has an immense impact on that, as well as your nuanced interpretation of the data and how it can be helpful for other clinicians moving forward. So congratulations again.
Thank you, Sepi. Thank you, everyone. It is our hope that these results will hopefully help other countries follow in the same path and start reimbursing in the public healthcare systems of low and middle income countries.